Okay, good afternoon everyone and welcome to this meeting of the Audit and Performance Committee. Can I first ask if there are any apologies for this meeting? Clark.
Chair, we have apologies from Lorna Burr-Stewart and Robert Peat.
And are there any substitutes?
No.
No, okay. Moving on to declarations of interest. Are there any declarations of interest in relation to any items of business on the agenda today? No? Okay. We now move on, therefore, to the only item on the agenda for this meeting, which is the annual performance report 2018-19. Could I first just apologise for the fact that the papers have only gone out on Friday in advance of this meeting today, and ask if perhaps the Chief Officer could give us an explanation as to why that was the case. Thank you.
Thank you, Chair. So, just to reiterate my apologies, essentially the delay in the publication or in the issuing of the report was down to myself not being available to sign off the report. I came back from leave on Tuesday, and it was only late on Thursday before I was able to sign it off because, unfortunately, of other commitments that weren't in my calendar before I went off on leave, but unfortunately diverted me away from this piece of work and this building to Nine Wells and Carsview, as well as St Andrew's House for most of the week. So my apologies for that, and I'm reassured that a couple of members have already acknowledged that they, despite that short time scale, have had the opportunity to read it, but I'm also now acutely aware that one or two will not have, so clearly that will influence how we progress the business today.
Thank you, Chief Officer. Usually we are required to have items at least 5 working days before the meeting in order to hear them. In line with the standing orders, therefore, the Chair has to rule that in his opinion an item should be considered as a matter of urgency under Standing Order 5.3. While not essential, I'm informed that the Scottish Government's guidance is that they would like to have the report by the end of July, which obviously makes that slightly more time sensitive. Therefore, if the committee members are in agreement, I'm happy to rule that in line with Standing Order 5.3 we hear the report. Can I just check that committee members are happy with that course of action, or content perhaps is the word? Okay, thank you. Right, we can now move on, therefore, to hear item 3 on the agenda, which is the Annual Performance Report 2018-19, and I'll ask the Chief Officer to introduce the report.
Thank you, Chair. So I am very pleased to be able to speak to this report. It's a product of significant endeavour by myself, but particularly a number of colleagues, and latterly during the period of my absence. So I'm grateful to them for getting the report to the stage it's now at, which I hope will be the final draft that the committee will see it fit to approve today, albeit there may be some additional suggestions or refinements that you would wish us to make, which we're happy to do. Some colleagues who have been key to the delivery and development of this work are with us today, and inevitably the Chief Officer's prerogative is to turn to them when the difficult questions are asked, because they know this report intimately and are far better sighted and perhaps better able to respond to any particular questions should they arise. In terms of the generalities, what I would say is that it was perhaps more of a challenge than we had anticipated to produce an annual performance report, given that this is the 3rd time that we've had the opportunity and challenge of doing so. One of my reflections coming in as a relatively new Chief Officer is that we need to be much more effectively monitoring and reporting on our performance, and I think that that's something that the committee shares, a view that the committee shares with me, having, I think, articulated that at the last meeting. So what I'm doing is bringing forward proposals and resources to ensure that we develop a much more robust and effective corporate performance reporting framework that will see us being able to deliver regular reports in future to the Audit and Performance Committee, and quarterly reports that will build up to enable us to more effectively deliver an annual performance report in future years. The important bit for me about that is not necessarily to satisfy the need for the Scottish Government to have a document. It's more about to satisfy the members of the committee that they can apply assurance and scrutiny, and for us as officers to satisfy ourselves that we are increasingly aware of the impact that our work and interventions are having and the difference that we're making to the lives of people in Perth and Kinross. We need to be better able to demonstrate outcomes. One of my cautions about this report, I suppose, is the focus that it perhaps has on inputs and outputs rather than outcomes, and talks more about measures of our productivity than our effectiveness. And I think we need to be conscious of that and attending to that and taking remedial action so that we're in a position next year that the report has a perhaps greater richness in terms of the experience of people who come into contact with services, in terms of the outcomes that they experience and the difference that our interventions make into their lives. That aside, what I would say to the committee, the report is framed around the 5 key objectives within our strategic plan. These are very clearly linked throughout the report to the Scottish Government's 9 health and wellbeing outcomes. The report also describes our responsibilities in the early section and our vision and values, and importantly makes connections between that to the work that we need to take forward to ensure that these enshrine and our activities enshrine the ambition of the Scottish Government's health and care standards. I suppose I was going to say new health and care standards, but I don't think we can say that any longer, just like in 6 months' time I won't be the new chief officer. Maybe I'm not the new chief officer already. So the health and care standards are critical because what they do is they talk about what people should reasonably expect from health and social care services. They're framed in the first person and they take a very much a human rights person outcomes approach. So we need to think about how we can demonstrate that we are delivering services that support the ambition of the health and social care standards, and those are mentioned early in the performance report. We've got information there about our localities, and then we move into section 2, which begins to talk about our performance. This is described in relation to the Ministerial Strategic Group indicators that all partnerships will be asked to report on, as well as national indicators, and elsewhere in the report we have information included in relation to our own self-evaluation, in relation to surveys that we've carried out internally. We've also included information in relation to the external scrutiny that's applied by the Care Inspectorate, particularly in respect of the registered care services and how they perform in Perth and Kinross. So throughout the report, we've got reference to the health and wellbeing outcomes, and each of the sections of the report reflects the 5 key strategic objectives within our commissioning plan. I don't propose to go through the report in any great level of detail. I'd be happier to open it up to questions. I'm certainly reassured that the way that we've presented the information and the information that is presented has made greater demands on our green print from the photocopier than our red print. Now that's an indication that we are performing well across very many of these indicators, and reassuring that we're making progress, albeit in some areas we need to redouble our efforts and address and mitigate some of the areas we're not doing so well. I shall stop there and invite members to discuss and ask questions.
Thank you to the Chief Officer for that introduction. Can we therefore move on to questions? Are there any members of the committee who would like to ask questions on the annual performance report? Councillor Drysdale.
Thank you, Chair. I'm not wanting to hog the microphone here, but I do have 21 questions, and I suspect you don't want me to ask 21 questions, so if you can give some sort of guidance as to how many I'm to be allowed.
If you think they're important, you can ask as many questions as you want. You might want to ask a few now and then we'll go to someone else and come back.
Yeah, I won't ask all 20 and then ask for a response on all 20. That's just
no, just ask one at a time and then that's the easiest way to do it, I think.
Okay, so I'm just going through this in the order found in the paper rather than in importance, and I just wanted clarity on 1 or 2 issues as we go. So on page 11, the forward and introduction, and the fourth paragraph regarding the strategic commissioning plan and the engagement with the people of Perth and Kinross. I appreciate this is an ongoing thing and we're still in July. I just wanted to get an idea from you as to what kind of volume of responses we have been receiving to the quite widespread request for input from stakeholders and members of the public.
Thanks, that's a really helpful question. I think it's really important that the work that we're doing as we develop our new strategic plan is key to thinking about performance and thinking about people's expectations and ambitions for services. We have with us today Maggie Rapley, and both Maggie and Diane Fraser have been at the forefront of some of the work, along with colleagues in the community engagement team and others. So with permission, Chair, I'd like to ask either Diane or Maggie to provide an update in relation to the coverage and response.
Thank you. We have undertaken a significant amount of engagement. Certainly we've received 900 comments, feedback from the engagement so far. We are engaging with communities, existing activities that are happening throughout the summer. We've been engaging, and we're also undertaking events with communities of interest as well.
Just to follow on from that, I'm not sure to what extent we want to discuss it at this meeting, but I just wanted to say that Councillor Stewart and I had a meeting with Mrs Rapley and Mrs Fraser about the annual performance report, and we did have a brief chat about the strategic plan. And although there is a lot of work to do looking at the responses that come in and trying to co-create this plan with our communities, certainly in terms of the format that you're now looking at to take it forward and focus on technology and other things like that, which seem to come directly from the engagement sessions that you had with IGB board members, I think that certainly from our perspective that sounded a really positive step forward, and something that's quite exciting actually, and could be one of the first board to do something like that in the whole of Scotland. So I think that's really positive. I don't know if you want to touch on it now or whether it's just to wait and see as we go forward. But
I think it's poetry in motion. I think we really should wait and see it. It'll be interesting to see the analysis that comes back from the engagement exercise to see whether that changes any of what we've already put into our prototype for the new look strategic commissioning plan. But I'm happy at a later date to come back and have a more full conversation around what we're developing.
thank you. Councillor Drysdale, your next question.
Thank you. This one's more of a presentational thing, and on page 13, under our vision and our values, we have in the bottom half of the page, on the left hand, a pie chart on our guiding principles, and on the other side, under the heading of health and social care standards, 5 pieces of narrative. And I'm just wondering, the previous paragraph makes reference to the National Health and Social Care Standards, which are set out in detail 4 pages on, and are not the same as what we've got listed there under 1, 2, 3, 4, 5. I just wonder, to me, that causes a degree of confusion.
Chief Officer.
Certainly, yes. The paragraph before that, the paragraph that says the National Health and Social Care Standards, we probably need a heading in there, and we need to present that differently, because actually these are the principles of the National Health and Social Care Standards, and these are the 5 standards that the five national care standards. So that is quite distinct from 4 pages on the national health and wellbeing outcomes, and if there's any confusion about that, we need to think about how we present it differently.
Yeah, it's just a presentation. Yeah, it's just a presentational thing that I just wanted to, because it got me furrowing my brow at that point. Moving on, then to page 17 and the Ministerial Strategic Group data that is presented, the MSG indicators that are presented there for Perth and Kinross. And I just wondered why we don't have comparative national figures for that particular chart.
Councillor, we actually don't have that data for MSG indicators at that level. They don't create a Scottish-wide value for these indicators. We run them separately. We can see everybody's different values, but we don't put them in here because that'd be too much data. And as a Scotland-wide one, we don't have that properly.
Is it something we may have in the future, or
We could ask for that.
be useful? Just you know, it's always useful to compare
Yeah.
local with national data.
I think the key thing about the MSG indicators were they were for our internal consumption and to help us understand how we were moving towards meeting these indicators rather than a Scotland-wide view of it. And
Yeah.
that's why it's a bit like that.
And it's particularly interesting within, just as an aside, particularly interesting within that data to see that, you know, we have 400, in round figures, 400 more people attending A&E and yet 400 less or fewer emergency admissions. So that's quite a striking piece of data.
Yes.
Thank you, Chair. Actually, I'm sitting with the ISD national figures on the rate of emergency admissions per 100,000 population and the total number of emergency admissions by board, and you can break it down in the margin to health and social care partnerships. So that data does exist, and I would agree with the councillor here. It would be really good to see that because, and I'm not, you know, I'm not taking away from the fact that you've got really good results here, but you have to see it in a national context, and agree with that. And also the rate per 100,000, although in global terms your number has gone down by 429, it's the rate per 100,000 population that's really important, and that figure's totally missing from the report. I think the other thing is about the A&E attendances, if I may, Chair, just go on to talk about that. And it's mentioned in the paper, and again there's a good narrative there. But given that we're hoping at board level at Tayside to see your commissioning intentions in September, I think we would be hoping to see something that would further reduce those A&E attendances, because having worked quite a bit on emergency care, it's most likely that 65% of people that go to A&E are what we call categories 4 and 5. They're patients who really don't need to be seen in A&E. But they often just present there because either GP access is difficult, or there aren't other out of hours or easily accessible drop-in centres or minor injury or minor illness or whatever. So again, I think because that number, that figure you quoted for 32,888 in 2018 is still quite high, and I think it probably doesn't compare. I haven't checked it with ISD, but I've got a feeling it probably wouldn't compare that well per 100,000 population. Again, that could be quite misleading. But from a commissioning point of view, I think we'd like to see what your plans are to take that down further. And I think all of this table needs to go in view of the councillor's comments with some A, 100,000 population, and B, the national figures.
Yeah. So there's 20 national indicators. They are in this document, and rate of emergency admissions per 100,000 on page 22. And that's where we do compare ourselves to Scotland, because that figure's more easily available there than the MSG. So the MSG indicators sound very similar, but they're different.
I think it'd just be good to maybe not worry so much about. I think what this report's got to do is inform the reader, and I wouldn't stick too slavishly to where the data comes from, but look for data which, because what you really want to see is a range of data, and you want to see it from different sources to see does it stack up. I mean, I'm sure you perform better than maybe the other areas, but again, if you're using resources to look after emergency admissions, that we don't need to be, we could do something different with that money.
Can I just follow on from that? One of the comments that I made, we had the opportunity to see the report in advance, was that the actual target or number wasn't included. And although you can perhaps try and work out, because I know that amber is within 3% or red is more than 3%, I thought it would also be useful, in addition to whatever the Scotland average figure was actually to see what it is that we're trying to meet as well, but that doesn't seem to have been incorporated.
I would go further than the Scottish average. I would go for upper quartile performance, because you want it to be aspirational as well. You want to say, this is where we are, this is what we're currently doing, and our aspiration as an integrated joint board would be that we would be in the upper 25% of performers.
Just following on from the point about national data, and I'm not suggesting that this can be done at all for this report, but perhaps going forward it would be useful to understand, because we always hear about the differences between NHS Scotland and down south, and it would be good to get UK-wide indicators just to see how well Scotland is doing compared to the rest of the United Kingdom. But again, that's one for the future, perhaps.
Your next question, Councillor Drysdale.
Right, so my next question is around page 18, sorry, and the narrative on that. I have a couple of questions on here. Firstly, it's in relation to the phrase diverted from hospital. In the first paragraph, focusing on early intervention, and this has led to people being diverted from hospital. And I was anxious to understand what is meant by that phrase, and insofar as possible to understand what the outcomes of these people who have been diverted from hospital has been.
I think it's maybe just an unfortunate language thing. That would be about prevention of admission, and so people would be seen at the front door of the hospital. We have put in services last year and the year before around frailty services, so we're assessing people at the front door of the hospital. So it means that on occasions people would not be admitted into a ward; they would be assessed first.
Yeah, it does. It could be construed as being, you're not ill enough to come into hospital, away you go, which I know it's not. Yeah, perhaps, yeah.
Chief Officer wanted to come in.
So I think it's also probably worth reflecting on the fact that a number of people will present at hospital who do so for the want of other service solutions, service offers. That might be about, maybe it's about carer breakdown, maybe it's potentially a social admission. There might be other opportunities that we're taking in relation to developing our care at home service, developing respite care, developing closer working with GPs, engaging with AHPs to ensure that people who need access to equipment can get it much more quickly. The range of options available to us there, I think, are things that we need to reflect on and develop and ensure that we're doing everything we can to ensure that those people who only need hospital care come into hospital, and that primary care, home care, social care and colleagues, partners in the third and independent sector have also got access to services that might enable people to stay at home for longer, more independently and safely.
Thank you. Councillor Drysdale.
Yep, thank you for that. That's helpful. References are made on this page and elsewhere in the paper regarding plans for the future in terms of improved data going forward and what have you. I'm conscious that Perth and Kinross Council agreed this year to fund was it staff, was it a resource in order to be able to get more data, and on the basis that was to, if that was to be matched by NHS Tayside, and I wondered if NHS Tayside had so agreed.
Chief Officer.
The Chief Executive of Perth and Kinross Council is currently pursuing that with Grant Archibald, Chief Executive of NHS Tayside, but at this stage we haven't agreed that much funding. So that will continue to be pursued at Chief Executive level, and should there be any difficulties in relation to NHS Tayside's ability to match fund that, I'm sure that the Chief Executive of the Council will be engaging with councillors to consider, and with the IJB to consider the most effective use of any resource that is not otherwise deployed.
Councillor
you.
Drysdale.
Moving on again, reference is made within the paper to the effect of winter pressures on operations. I wondered if somebody could give a flavour for the experience of summer pressures and the effects of the current so-called good weather and temperature rises and so on, and what effect that is having on hospital services.
Evelyn sat well back when you asked that question, which is perhaps a reflection on the challenge it presents us. I doubt that we have any information or data other than anecdotal in relation to the significant impact, or the impact, significant or otherwise, of the humidity, the heat. Absolutely, that is likely to be having an effect on people, older people, frail people, people whose immune systems are compromised. I don't know, Evelyn, if we've got any indication, even in terms of a spike in presentations, and whether or not, I doubt that we would be able to attribute that to the weather, but sometimes it can be a consequence of carers going on holiday over the fair fortnight, so it's difficult to know.
We certainly have had a spike in terms of admissions on a more regular basis, in terms of the growth of admissions coming into the hospital over this summer period. We have, it's really, it is fluctuating. It's not steady, but it does appear to be a bit of a spike. Yeah.
Sorry, can I add something? That the seasonal nature of emergency admissions has really disappeared now. It's been overtaken by the demographic factor, which is if you're old and you're unwell, it makes very little difference now. We used to see a big spike in, you know, fractured neck or femurs and people falling on the ice, or people developing community-acquired pneumonia. In fact, we don't see that now. And if you talk to people in A&E departments, they'll tell you it's just basically throughout the year. There's no seasonal adjustment now. That's a thing of the past, really, because of the ageing population.
Chief Officer.
Thank you for that. That's a really helpful insight. I mean, I think it probably is why we're starting to get away from talking about winter planning to just thinking about how we provide responsive services. I think, Councillor Drysdale, though, your question will prompt me to have some discussion with colleagues to ensure that in our engagement with private home care services and thinking about heart, that we are particularly sensitive to the vulnerabilities of the older people with whom we're supporting, who may be exposed to humidity, experience dehydration, acquire UTIs, go into hospital, and or worse. So we will take that as something that we need to reflect on and encourage our staff to be attentive to moving forward.
Thank you.
Clearly that's not something that's going to change anytime soon in the climate emergency that we have. Okay, thank you for that. Moving on to page 19 and the table there.
Well, just perhaps, because that might be a good point, to see if anyone has any other comments on the introductory section up to about that point before we go into the strategic objectives. Is that all right? Yeah. Yeah. Okay. Ms. Campbell.
Sorry, can I just would like to make a comment. It is on page 13 and it's a positive comment. I'm very pleased to see the reference in our vision and our values includes the health and social care standards and exactly what service users and carers, the expectation that their service they can receive. Just on the comment that Councillor Drysdale made, we say here the health and social care standards. I'm not sure if that's just a sentence or if that's actually what the document is, but the document is actually the health and social care standards, my care, my life, or the health and social care standards, my life, my care. I can't remember exactly, but that might clear up the moving on into the section when we talk about the national outcomes. Is that?
Chief Officer.
Thank you, that's really helpful. I wonder if we should also introduce a hyperlink for people who are reading this report who are, or who are seeing an electronic version of this report that can take them straight into the health and care standards and enable them to look at them in detail.
Mrs. Summers?
It's about the table on page 17. Just clarification, because I'm not sure what that means. On the 6.1 on the table at the bottom, the percentage of population at home unsupported, 97.97 for 16-17, 98% for 17-18, and not applicable for 18-19. Why is that? Is that because we're still in the middle of that year, or have we no indication as to how it's? Yeah.
They won't have a completed year of data. No. You know, they'll collect it for a whole year, and they won't have a completed year, so they won't publish it.
Just not applicable. It's applicable, you know, but it's we've no idea how it's going.
The data will be available in October 2019. That's what I've got on my version at the bottom. Yeah.
So we'll know by October.
Or maybe beside the not applicable, maybe that might be more clear. There we go. Any further questions or comments up to page 18? Councillor Stewart.
Sorry, can I just
sorry.
ask about the readmission, hospital readmission rate, which is on the way down. It's on the way up. It should be on the way down. Which is showing a 16% deterioration, and not so much about the. So I'm on page 16 on the table. Performance relating to strategic objective 3. Have I jumped ahead too much?
Page 16 of the report rather than what's that? If you look at the page numbers.
That's not very helpful. We have two different sets of page numbers, so
I'm working on the report.
So we're up to page 10 then on the report.
Right.
Sorry.
All right. I'll hold my question
then. Councillor Stewart.
Thank you. Obviously, I'm here just in attending the meeting, non-voting capacity. I think, firstly, quickly draw attention on. I know we were talking. You touched briefly on the strategic commissioning plan, Chair. Just to flag up that we've got in that forward and introduction a reference to the fact that it is a 2020-2025 strategic commissioning plan. So we are looking to extend beyond the 3-year period that is required of us and take a longer look. And I think that's
Chief Officer.
A really
Things that happen on holiday. Thank you for pointing that out, because I think we have to be very cautious that as officers in the preparation of our strategic commissioning plan, which was intended to be a 3-year document, we took a view that it would be worth making a recommendation to the IJB that we think about a 5-year time period, and we checked in relation to the guidance from Scottish Government and the plans that are developed by other partnership areas that is within our gift to do. So the fact that we've said that in the annual performance report, I fear preempts a formal decision that we might need from the IJB in that regard. The IJB, I think's expectation at this stage is that it would be a 3-year plan. And I know that both yourself and the Chair have had sight of the development work in relation to the strategic commissioning plan, but I don't think there's been a formal decision that it would be a 5-year strategic commissioning plan.
If I may offer in that regard, see that sentence. There we go. Thank you. That sentence that starts a new 2025 strategic commissioning plan, and also ends with "and will be issued at the end of September 2019." Perhaps we might couch that in slightly less certain words, given that it's subject to approval, and maybe it should reflect that it is planned to be issued at the end of September 2019, and we might just simply lose the 2020 to 2025 bit.
And I think that goes with the comments earlier. Although they were informed by the board member session, obviously they'll still have to get approval of the format as well as the timescale by the board on the, I think, 27th of September, I think.
Can I just say there was some consternation at the NHS board that these were being delayed till September. that being the only IJB that was delaying their commissioning plans. I think I'm right in saying that, Colin?
I think it was. I think it was commented on, but there was recognition given for the very good reasons why the IJB had chosen to delay.
Yeah, and I think that's
Yeah, but you wouldn't want it to go beyond that much.
absolutely
All I'm saying is if you're in planning process and you've got drafts and things, as long as we can have a reassurance that it will come within that time scale.
And I think the key point there is to ensure that, okay, there are reasons for why we've got this report when we have, but if we are looking to have a final decision on the 27th of September, that all board members have sight of it sufficiently in advance of that meeting so that we can look to take a final decision. But I think, you know, I can understand the NHS Tayside Board's concerns, but there were clear reasons why the board, this board, felt that we needed to delay it. No, certainly not. Okay, Mrs. Summers.
Just ask if changing it to a 5-year plan, is it really a 3-year plan that you're giving yourselves another 2 years longer to fulfil a 3-year plan? Or is it going to be monitored on an annual basis to see what progress has been made? And are you setting targets for each year over the 5 years?
Chief Officer.
I might ask Maggie to come in here, but I think probably when we talked about a 5-year plan, we felt that that was a more realistic timescale in order to deliver discernible improvements, and that indeed, yes, that would be about 5 years of work. We weren't giving ourselves more time, but what we would do, and you're right to highlight it, is provide annual reports on progress to the IJB throughout that 5-year period. Is that?
But will you be setting targets for each year so that we can see that it's on target to be completed?
Yes, we will be doing that. And underpinning the plan will be delivery plans, and they will have clear milestones and targets within them.
And I suppose reports, although they're not exclusively in this format, but reports like the annual performance report, which is being measured up against the current strategic commissioning plan, will help fulfil that monitoring process. Councillor Stewart, you had more questions.
Okay. Just picking up the theme of the National Health and Social Care Standards, can we check when they were published? Can we confirm that?
July the 22nd, 2018.
When I had looked them up on the, I found a Scottish Government website, I thought they came into effect earlier in the year than that. No, July. Okay.
The new health and social care standards, which now applies across all services, hospitals included, it is July 2018. And I think that's the confusion. The previous ones were the national care standards, and if you put that into Google or whatever, it might come up as 2007 or 2010. But so it's
no, I had just thought it was earlier in the year. I must have found a dud redundant web page, but just if that's been clarified.
The Chief Officer wants to come in.
Because how much more quickly time passes when you're having fun, I may well be wrong. It may actually have been this 2017 that the Minister approved them, the 22nd of July, I think, in anticipation that the implementation date would then be the 1st of April 2018. We can clarify that for you. Jane's maybe Googling it as we speak.
Thank you.
Councillor Stewart. Oh, no. Do we have any further questions, therefore, on the first 10 pages of the report or the first 18 pages of your document pack?
Sorry, yeah, just to flag up something else.
Okay. Councillor Stewart.
Sorry. On page 6 of the report, or page 14 of the document pack, I just wanted to flag up, although we were talking about high numbers of A&E attendances in terms of some of the other measures there, at the top there we have got 364 attendances at A&E in Perth on average each week. 97.1% attendances seen within 4 hours, which I think is substantially better than the national benchmark, and I thought it was worth just flagging up the excellent performance in that respect.
Thank you. Councillor Drysdale.
Yeah, it was more of an observation really, and just to emphasise, if you like, the particular challenges facing us in Perth and Kinross. When you look on page 7 of the report, on page 15 of our papers, and the narrative and the map on our localities, where you see that in North Perthshire, the population density is 10 people per square kilometre, and in Perth City it's 1,625 per square kilometre, an entirely different proposition in terms of delivering health and social care. So just wanted to flag that up.
Okay, thank you. So if we now move on to page 11 or 19 of 58, and on to strategic objective 1, which is working together with our communities. Do we have any questions on the first strategic objective? Councillor Drysdale.
Thank you, Chair. I shall continue. One question on the table on page 19, the second bottom line around number of bed days lost to delayed discharge, and comparing these figures with figures later on which are different, and I managed to work out for myself that the difference was excluding complex cases. So doing a bit of mental arithmetic, and I discover that in 2017-18 there were 1,707 days of delayed discharge for complex cases, rising to 2,757 in 2018-19, so that's a substantial increase, clearly. I'm just wondering if I can understand better, and to be fair, in 16-17 it was a higher figure still, so just wanting to better understand the the reason for that kind of level of fluctuation in data.
Who wants to take that?
Thank you. So complex care refers to people who may not have capacity. And so guardianship, or people who are, have very complex needs who require specialist provision. And we have seen an increase in the number of people requiring support who don't have capacity, who are in hospital delayed.
So it's not a question of resource specifically to deal with that, it's more a question of putting the process in place.
Yes, yes.
Okay.
Chief Officer?
However, the resource challenges are significant and will be significant as increasingly we look to support people who have that level of complexity to move out of long stay hospital and into supported living settings, and we would also have an ambition to look at designing locally services that might repatriate people with very complex needs who are placed out of area. I think it's worth mentioning that because we will be reporting to the BRG and the IJB on the significant pressures that brings to bear throughout the course of this year as we design these packages to ensure that the people who need that level of support are able to receive it, as well as the discussions that we need to continue to have with NHS Tayside about the contribution that they may or may not make to these individual packages moving forward. So the resource issue will become a pressure as the year progresses, and we will report separately in that respect.
Thank you, Chief Officer. Any further questions? Councillor Drysdale.
So page 21 or 13 of the papers and the adult social work survey, and the response rate, which is down at 26.5%, how can the response rate be improved?
Mrs. Fraser.
Thank you. This is an area we're looking at across all our services, not just adult social work and social care, in terms of how we engage people and how we gain their feedback. So certainly we have been doing work with particular areas of the service. So for example, we have a survey for individuals who use the home assessment recovery team, and we do different surveys, and we have different methods of trying to engage feedback to improve our services.
You okay with that? Thank you.
Next, on page 23 or 15.
It's going strategic objective.
All right, sorry.
Is that all right?
Okay,
Just in
yep.
case there's anyone else who has on the first strategic objective. Chief Officer, do you want to comment first? Okay.
You got a question? No.
Yes, well, I have got a question. I'm going to challenge myself because, no, I had thought with respect, Councillor Drysdale, that you, like me, may well have highlighted the fact that there is a deteriorating picture in relation to the number of people who feel part of the local community. Now, given, as members will have heard me commit to previously, that we are going to be embarking upon redesign and delivery that seeks to ensure that community connectedness, that enables people to feel part of their local community, that enables people in communities to look out for that this is an area for priority moving forward, and I would be very keen to try to get beneath this figure to try and understand exactly what led to that deterioration, so that that can become part of our strategy for moving forward to try and ensure that people are much more engaged.
Councillor Drysdale?
Yeah, just following on from that, Mr. Patterson will be aware because he's retweeted a tweet that I tweeted regarding, in particular, one community council that I'm involved with, which is becoming quite active in terms of, not always pressurising for things that they want, but actually how can they help improve the lives of the more vulnerable people in their area. And I wonder, just in general, if this kind of survey, rather than relying on purely traditional means of asking for input, if we could use the community council infrastructure to try and get better response rates going forward.
We did mention when we had our meeting about the strategic, well, it wasn't about the annual performance report, but we touched on the strategic commissioning plan, exactly that the community councils have a great local infrastructure that we should be making use of. And I think that certainly in the case of the strategic commissioning plan, that is happening. Just maybe more broadly, would someone want to answer Councillor Drysdale's point about making better use of the what is the lowest level of democratically elected representatives in our communities?
Yes, we're looking at those structures locally. We have health and wellbeing networks that are connected to the local action partnership. So again, it's looking locally in terms of the infrastructure and how we can connect with all the structures. And our locality service managers will be absolutely key to that.
I think we just need to be clear, though, that community councils are distinct statutory bodies, and although local action partnerships are set up under the Community Empowerment Act, they are separate and in some cases crossover, but not in all cases. So just to make sure that we do address that gap. Chief Social Work Officer.
Thanks, Chair. It was really just to say that, although this is providing the results of the social work survey, I think it's important not to rely on one area or a piece of data. I think it's very important to think about how people report on how they experience services within the service that they're receiving, and that we actually pull that data forward and report on that, and that feeds into what the Chief Officer was saying about outcomes, because this is about how people are, how their lives are changing as a result of that. So it's not. So I think I'd like to see a bit more in terms of how else are we obtaining information about how people are receiving those services.
but I know that there was some questions around how people feel part of their community and a challenge around that. But if we focus on the 95% of people, when they were in contact with someone or some service, felt that they were treated with compassion and understanding, and that's 95%. And that's quite incredible, because it's actually people that make a difference. So that's about how people are receiving those services. So I think the staff involved in that need to be congratulated.
That's a well-made point. Mrs. Campbell, you wanted to come in?
Yes, sorry, actually, my question was in relation to the response rate of the 26.5%, but I actually see that it's in the text. I was wanting the numbers, but it says that it was per 1,000, it was sent out to 1,000 service users, so apologies, I hadn't read the report, so I didn't see that. Thank you.
It's okay. Councillor Stewart.
Thank you, Chair. It's, I think, going to be a recurring comment in terms of the presentation of the data for some of these national indicators, and again, for each strategic objective. If you went to National Indicator 19, the number of days people aged 75 plus spend in hospital when they are ready to be discharged per 1,000 of population, the trend over the last 4 years is down 407. So we're now sitting at a figure of 598 from 1,005. That reduction is quoted as, the trend over the last 4 years is quoted as 68%. If there'd been a 68% reduction from 1,000, we would be sitting at well below 500, rather than above 500. 407 is 68% of 598, but you can't take the last 4 years, the reduction over the last 4 years, and express it as a percentage of the number attending last year. And then the same below, you can see that from 17,000 bed days lost due to discharge to 11,500 last year. That's not a 48% decrease, but it is a reduction of 5,583.
It's not comparing like with like.
We'll double check these calculations and correct them if required.
Okay, so it's not just here. It
that
occurs,
patterns throughout.
That pattern repeats throughout the number.
Mrs. Summers, did you want to?
Sorry, going back to page 21 again. The bottom line, the bottom one on that table there is, I get a good response from social work services when I contact them during the day. Do we have anything further on? I mean, I've only just got this report tabled here, so I haven't had a chance to read further on yet. I'm just going through it as we're going through it. But is there something later on about out of hours and the percentages of success for the out of hours services provided?
Mrs. Fraser?
No, there's nothing specific about out of hours, but certainly that's a piece of work that we're looking at across social work services, because out of hours provides services to all ages, so it's something we are looking at. So no, in this report there's nothing about out of hours specifically, but that's certainly something we could take into consideration.
Is that being considered, and is that going to be included at some point, or how do we see how out of hours services are progressing, or what's expected from the out of hours services? Surely that should be included in this report too.
There certainly is an intention for us to look at out of hours services across the health and social care partnership. This question relates to adult social care services during the day. So I suppose it's quite difficult, because out of hours is not necessarily within the partnership's gift. It's a council service across children's services and adult services. But as a partnership, we are committed to looking at out of hours services and reviewing them.
What report or what document will that be included in then?
That should be part of our. That will be part of our strategic plan over the next 3 years.
Which we'll be looking at in September. Yep. So we'll get to see it in September. Any further questions or comments on the first strategic objective? Oh, okay, if we move on now to the second one, which is prevention and early intervention on page 14 or 22 of the document pack. Councillor Drysdale, do you want me to come to you first? Okay.
Sorry about that. Yes, found my place now. So on page 23 or page 15, depending on where you're looking at it, the third last paragraph and the activity around smoking cessation. I note with interest that there has been the provision of what's described as an incentive scheme to those living in the 40% most deprived areas. And I'm keen to understand what that incentive scheme involves.
The information was provided to us by Public Health and unfortunately not represented today, but we can certainly get the detail to you. I wouldn't want to give you that detail at the moment, but we'll get that to you.
That's fine. Okay, that's all on strategic objective 2 that I had.
Okay, any other members of the committee have questions or comments? Councillor Stewart.
I think I just wanted to check, there's a note at the bottom of the table, the 3 asterisked note, which says that changes upwards and downwards in reablement data don't imply better or poorer performance, and I didn't quite understand that. Why don't changes in reablement data reflect changes in performance?
First part of that is because we're not in control of the type of person that's approached us for reablement services, and I think I give an example where if in fact everybody who came into the system in a particular month needed reablement and no further activity, we'd have a 0 there. But that doesn't mean we failed. It means that everybody needed support to stay at home safely. So it's a very hard one to say that we're in control of how well they are able to be re-abled. As I've been, I mean, that's a question we've had for a long time, and that appears to be where we are. We are at the mercy of the type of person that comes to us.
Is that okay, Councillor Stewart?
I'm still not sure I fully grasp that. If the question, if the question isn't giving us useful information about the performance of the service, then it's a measure that we shouldn't be using. But sorry, head of.
Yeah, we have thought about this in terms of improvements, and for ideally we would like people to be as independent as possible and not require further support. That would be the aim. But you're absolutely right. In terms of the next iteration of our performance, it is really about whether people come into the service and actually potentially reduce their support. That could be something we could measure, but again, it may not give us a definitive answer in terms of the improvement and the quality. So it really is about the experience for the individuals who are coming into reablement and whether they feel more independent and they are optimising their independence throughout the process. So it is something that we're looking at.
Okay, thanks.
And I suppose just a more general point, not specifically about this reablement, but in terms of the performance indicators that we have. If we're talking, in some of the cases it's, 1, 2, 3% changes, that's, okay, I don't know the exact way that you've calculated all the information, but other than sort of the sample size, but it's probably, if it's that level, then they're probably statistically insignificant in terms of the changes. So we shouldn't necessarily get too hung up on ups and downs necessarily.
Sorry, just to say that it is actual, so it's not sample sizes. We do take the actual numbers.
I was meaning for some of them, for like the survey, the social work survey that we were talking about before. Any further points on the strategic objective 2? No? Okay. If If we move on now to the third strategic objective, person-centred healthcare and support. Does anyone else want to go first this time? No?
Can I ask about readmission? So I'm on page 16 of the report. And we're talking about readmission within 28 days of discharge. And obviously, you know, that will fluctuate up and down. But do we have the top 5 reasons for readmission? So do we know what services, what kinds of are these secondary cancers? Are they respiratory patients? Are they atrial fibrillation? What are they?
We've just begun as part of the Older People Non-Scheduled Care Board to do a deep dive into this, so we don't have all the information at the minute, but it's a piece of work that's ongoing just now in terms of readmissions within the 28 days.
Yeah. Will that be reflected in your commissioning intentions?
Yes.
Thank you.
Mrs. Summers?
I've just noticed something on page 22, if we could just go back there, the last paragraph. Through 2018-19, the Health and Social Care Partnership has been transforming services to focus on prevention and early intervention activity. This has resulted in a reduction in unnecessary hospital admissions, more people with mental health or drug and alcohol problems in recovery, and more people supported to live independently at home. What has been done to enhance the mental health services then? Can you elaborate on that? Because I don't think it's reduced the problems at all.
Who wants to take that?
I wonder, Evelyn, if there's anything, or Diane, in relation to the mental health strategy and the work that we're doing in communities, or the Action 15 monies, whether those are examples of how we...
So, I think this is in relation to 2 things. It's to do with the pipeline that's been introduced around the drugs and alcohol services, around early intervention, but also in relation to prevention of admission and early investment with using our Action 15 monies. We've invested in and around, as you know, enhancing our third sector commissioning, primary care liaison nurses, our link workers attached to the GP practices. So that's in relation to looking at becoming more upstream in relation to early intervention and prevention for those people dipping into crisis. Obviously, Maureen, you know there's a lot more work to do, and we've begun a series of workshops looking at engaging with both our public users and carers and services and our staff around what we do have available in our communities, of which there is a lot, but it's how we're linking them all together and making best use of our resources. So that's where we're at the minute. Obviously, we've got a lot more work to do, but it's ongoing.
Have the community mental health teams been enhanced, and if so, by how many staff, you know, in the Perth City in particular, who have the bulk of the people that are mentally ill?
So we've begun a workforce planning exercise around our community services, as you know, and we're looking at the future and enhancing our services as we move forward. That's all tied up with transformation and release of equity from inpatient services as well. So, but we're very much looking at enhancing our community mental health services.
It's really frustrating because we've been looking at it for so long, and you know it's not actually happening. And if it is, it's not making any impact. I mean, there's more people severely mentally ill in the community now, and more suicides. The suicide rate is increasing. There's been 2 in the last few weeks. I mean, when are people going to get real help? You know, not just looking at protocols and strategies and documents and that. That's not helping people. It's the action in the community and people being told there's going to be, you know, another 4 or 5 extra staff in the community mental health team in your area, and this is how you access it. People need to get the information out there because people don't know really what help is available, never mind enhanced help. I really don't
I feel quite confident about the piece of work we've started in relation to engaging with our public. You know, we're taking that out into localities as well as, you know, as well as in Perth City itself. So I think, you know, we have a good programme in place. There's been a lot of hard work put into it so far. We just need to keep going with it. It's going to be an ongoing process. And we've got a lot of our voluntary sector people that are willing to help us to do that stakeholder engagement as well. So I think we're building a good programme, of which you're part of it.
I think the Chief Officer also wanted to comment.
So I just wanted to commend Maureen for her passionate plea for additional support and greater clarity in and around this very difficult, challenging area that we need to reflect on. And it's encouraging that you are involved in the strategy and involved in some of the discussions around the planning of the work going forward. But what I am sensing here is something that I'm sensing elsewhere, and that is about the need for us to bridge the gap in public confidence and to ensure that we are able to demonstrate that we are committed to doing everything that we can to ensure that people with mental health problems are supported earlier and more effectively. So we'll reflect on that and think about how we can engage and involve and potentially invest. I'm looking at Jane here, in services that will take the pressure off inpatient mental health. And what we also want to do is to release some of the resources that are tied up in buildings to put into third sector organisations, community cafes, peer support and other types of services that will be part of that end-to-end strategy that we need to develop.
Thank you. If we just hop back to Strategic Objective 3, I think, Councillor Stewart, you wanted to ask a question.
I wanted to
well, back to forward.
Sorry, I just wanted to follow on from Maureen's point, and I'm wondering if Maureen's point was really... If Maureen's point was really about the fact that the document actually says it has resulted in a reduction. You know, it's not saying that this is what you're doing in planning, it's actually clearly saying that it has resulted in a reduction in unnecessary hospital admissions and that there are more people supported in the community, and I think that's possibly more of the query. My other point is there was a comment with regard to, I don't know if it's community mental health teams, but being available in GP practices now. Is that something, are they available in all GP practices? Service users or carers, are they aware that this service is now available in their GP practices? I'm not sure that we're aware of that, so thank you.
Mrs. Rapley.
Yeah, it's really just a comment around the where we're saying this has resulted in a reduction in unnecessary hospital admissions. We absolutely have seen a massive reduction in terms of our older people, in terms of mental health care for older people and in dementia care. And that's been with a disinvestment and reinvestment over the last 5-year period, which has been particularly successful. So it may well be that comment needs to be expanded out and be specific to older people, because that really is where we're seeing a big difference.
Do we have any measures or indicators that could help justify that? Because I suppose the other ones are a bit more general in terms of emergency admissions and things like that, yes, rather than linking, unnecessary admissions and then to the specific groups in order to better understand the effects of any early interventions. Otherwise, as you say, it's just a sentence which may well be true, but it is not substantiated.
Could we maybe have that amended then so that it reads that refers to psychiatry of old age rather than adult services? Because there's a big difference, it's not actually happening in adult services yet.
Okay, thank you. Any further questions on that area? Where was your question, Councillor Stewart?
The Strategic Objective 3.
Oh, thank you. On you go then.
So, before we get to the What Matters to You page, there's a section with the recovery pipeline. There are 3 lines at the top of page 18 of the report, which are relevant to what has gone above, but then there's been a continued emphasis on developing a recovery approach which puts the individual at the centre of care. This is about recovery-oriented system of care, recovery pipeline, and it doesn't seem to me that it goes with the measures that are on Strategic Objective 3, which are about supporting people at home, admissions and discharges, and so on. And in particular, if you went back to Strategic Objective 2, there we are talking about things like substance abuse, alcohol, brief interventions. So I wonder whether the recovery pipeline section and paragraph is in the right strategic objective. Because otherwise, if you're talking about the recovery pipeline and the recovery-oriented system of care, there are no indicators above which that relates to.
Head of Adult Social Work.
I think the recovery-orientated system of care is important in terms of delivering person-centred care, supporting people to be at home, supporting people to access employment. So, yeah, well, it doesn't specifically relate to the indicators highlighted. In terms of the work that's undertaken, the ethos behind recovery process, I think that it does fit within strategic objective number 3. And it was to provide an example of that person-centred care.
Okay, I see how it could fit in there. When you put it like the person-centred care, I guess it would be useful to have indicators that were reporting against it. But I know we had a report at the IJB, but okay.
Yeah, fine. Next year we will have further different performance to be able to report.
Was that your only question? Councillor Trisdale.
I'm not sure. I want to ask a question now, but I will just, you know. Obviously, what Ms Kilpatrick was asking about is the key issue for me in here in terms of the hospital readmissions rate, which is deteriorating and outside the national average, which is disappointing. I note also that within the same table of data that there is a smaller but nevertheless unwelcome deterioration in the views of adults who think that their health and care services seem to be well coordinated, which of course is what we are all about in the Health and Social Care Partnership. And I'm worried that these two pieces of data may be related, that the reason for readmission is because the whole integration between the health service and social care provision when people get out of hospital isn't as strong as it would be. I appreciate that you know that's a worry rather than a statement of fact. But the narrative later on the following page that speaks of the work being done to properly understand the reasons for these the increased readmissions is very, very important, and it feeds back to that question I asked earlier about resource for analysis of data. I think it's critically important that we really get to grips with this particular piece of information and find out what's going on and why and what we can do to improve it.
Can I come in there? Because quite often you find in Northern Ireland, if you look at the way that Northern Ireland, they have higher readmission rates, but they very often have higher readmission rates in rural areas, and they have used community hospitals, which are not very popular in Scotland, but they've used them as a way of keeping you away from the big acute units where you pick up infections and become unwell and your relatives necessarily can't get in to visit you. So step-down beds in the community sometimes just takes a bit of the edge off that in rural areas. And it might be that in North Perthshire that might be closer to your solution. I don't know, but you need to know the reasons for it. It could be medication compliance, it could be all sorts of things. And I know a lot of respiratory patients are readmitted for the whole of Tayside, so there's questions about that. But it might be the rurality issue.
And that is something we've discussed at length in the past, particular in the budget review group sessions. So when we have the next one of those, that might be something to get an update on. Any further questions on strategic objective 3? No. Okay, I've had a request for a short comfort break. And in line with our person-centred approach as an organisation, I'd like to be as accommodating as possible. So I'll grant that request and we can have a short comfort break. Okay, 5 minutes. Right, we shall now reconvene for the Audit and Performance Committee. We were at Strategic Objective 4. Are there any questions on that? That's page 20 or 28. No questions on it? Disappointing. You joking? Oh. Councillor Stewart.
I can see the link in. I just think that there is a risk that once we start talking about some of the things under Strategic Objective 4 to do with employment support team, MECOP, St Johnstone Community Trust, Perth Pride, we are I think we just have to be very careful that we're not confusing community planning outcomes with health and social care partnership outcomes. There are other mechanisms that the community planning partners can use to report separately on those, and it just potentially risks taking away focus. It won't be anybody, within the health and social care partnership, I think, that's directly responsible for, they may be involved, there may be contacts, but I think we should maybe just be careful to keep a very tight focus on what the health and social care partnership is responsible for delivering and the outcomes that we're achieving, rather than necessarily reporting all of these linked in projects.
Anyone want to respond to that, Mrs. Fraser?
Thank you. This is an area that we will be absolutely focusing on as part of our strategic plan in terms of reducing inequalities and, as you rightly say, in terms of what we're directly responsible for. But we did feel it was important to highlight the partnership work that we have been doing over the past 3 years around reducing inequalities and working with our housing colleagues, children education services, and has been a really important piece of work in terms of tackling inequalities, which we felt we needed to recognise within the annual performance report.
Mrs. Kilpatrick.
I mean, I think it's some of the statistics here are impressive. On the premature mortality rate, and as the chair of the NHS Tayside Public Health Committee, that will be one of our key objectives of our public health strategy, be to reduce it further. I think what that figure isn't really that helpful, but because you look at that and you just give yourself a pat on the back and say that's great. But I think it would be better if you focused it on the SIMD categories, the quintiles, to say of those people who live in SIMD, whatever it is, 4 and 5, and who live in poverty, are we increasing their life expectancy? Because if you're affluent, you've got 2 cars and you've got a big house and loads of money, your life expectancy is probably going up. I think the other thing that you might want to note in the report, that as the direct effect of, and I don't know whether you want to say austerity or reduced incomes, especially in the lower social categories, there is a national UK-wide trend to deterioration in life expectancy, i.e. it's reducing, but that your efforts are focused on those SIMD quintiles. So that's what you're trying to do. Otherwise, by lumping everybody together, back to your equality issue, it's not really that, it looks good, but it's not really that helpful for you as an organisation. Thank you, Chair.
Anyone want to? Are we happy to acknowledge that point? Okay, Councillor Drysdale, you had a question.
Yeah, thank you. Regarding page 29 or 21 of the paper and the 5th paragraph down on that page, where we speak of transition from school to employment can be challenging for any student, particularly so when facing barriers such as illness or disability, and we go on to mention the work of the employment support team in relation to Fairview School, which is good. Just regarding people with physical disabilities, because maybe it's just me, but we don't talk an awful lot around this table about people with physical disabilities. We talk a lot about learning disability, and we're right to do so. Less so, I feel, about physical disabilities. What are we doing? What more can we be doing to help people with physical disabilities find a role in society and work that gives them a better sense of well-being?
Fraser?
Thank you. The strategy for people with physical disabilities is part of our Older People and Unscheduled Care Programme Board. We have recognised it as a priority area. We are seeing an increase in the number of people with physical disabilities who are using our services. So again, it's how we intervene early. So one of our areas of work is to begin to look at what we can do in terms of early intervention, prevention, employment support, working with primary care when people are initially diagnosed. Can we support people at diagnosis stage to ensure they have the right support?
Yeah, I mean, and that's all good. I get that. I know a number of people that either currently live or have lived in the past at Upper Springland at Capability Scotland, and some are very physically disabled and not able to work, sadly. But there are others who could perform some sort of function and could obtain some sort of work. One individual in particular who is in his early 20s that I know that is really desperate to do things, and I just wonder what help is available to them. Obviously, they each have social workers that will liaise with them and talk things through, but it just seems to me that there are, whether we like it or not, a number of people out there who could be working or could be contributing to society and want to contribute to society, but they're unable to obtain any form of work that suits them.
And that is, in terms of the work we would do as the Employability Network, we're a partner within the Employability Network. It is working with local employers, encouraging people to look at supported employment and work with us to support people in employment. We work closely with the local colleges, but absolutely, in terms of creating the right job opportunity or employment opportunities for individuals, it is challenging, and it is something we are doing with the Employability Network. But our employment support team is to support everybody, whether it's a physical disability, or whether somebody has a mental health problem or a learning disability. So it's finding the right employer to support people.
Okay, thank you.
Mrs. Summers.
I've actually noticed an increase in people with physical disabilities in, like Asda's and, other shops and that, that the sorry, I thought I switched on. Whether it's an obligation that they have, or whether it's a change of heart, that they don't want people that are going to give 100%, but they're going to assist them to do what they can do, But I have seen a lot more disabled people working in shops and around the place, and some of them quite severely disabled, stacking shelves or doing, jobs that putting the trolleys, you know, taking the trolleys in, you know, but it all adds to them feeling, you know, fulfilled and part of society, like, you know, the fact that they're getting that opportunity, you know.
Thank you. If there aren't any more questions on Strategic Objective 4, we'll move on to Strategic Objective 5, which is making the best use of people, facilities and resources. Do we have any questions on this section of the report? Councillor Drysdale.
Thank you, Chair. Yeah, I do have 2 or 3 questions on this section. The first one regarding page 32 of our papers, or page 24 of the report, and a reference made to absence data, staff absence, sickness and so on, staff absence. Just wondering whether this data, whether this committee is going to have the opportunity going forward to have oversight of this side of things, so that we can fully understand the nature of the pressures on staff.
Chief Officer.
Certainly, yes. This is an area that I'm interested in, and that interest was on my return from leave. The Chief Executive of the Council highlighted that I think she had been cited on some figures that suggested that we, particularly council employees within the Health and Social Care Partnership, are performing less well in relation to attendance management than other council departments. So whilst it will be something that we need to look at in relation to both NHS and council employees, it's absolutely essential that we're getting below what are the issues that might be contributing, what can we do to support staff, how do we identify early on what is needed to perhaps offset the effects of workplace stress or work-related stress. Are we doing enough to prevent lost days through musculoskeletal injuries and strains, and what are the other key factors that are impacting on the availability of our staff to work and deliver services. So we will look at that, and because that is about performance, that is something that can be reported to this committee, certainly, either specifically or within a suite of measures.
Thank you. Mrs. Kilpatrick.
I'm also quite interested because the public health budget supports 8 full-time equivalent staff from public health in the Healthy Working Lives programme. And the indication of the figures that I received from NHS Tayside for their staff alone indicates that the sickness rate has gone up. Now, you know, there are a lot of pressures in the health service, a lot of pressures for our staff, but there is a question about whether investing 8 full-time equivalent for an absence sickness, that absence level that's going up, is effective, or in fact would it still be that without these 8 people doing whatever they're doing with Healthy Working Life. So we've asked to bring a report, and obviously that would have an impact on you as well, so we would share the findings of that. But that's a wee bit worrying, because we would have expected with that amount of resource investment for the sickness absence. You know, if you're a private company, you say, well, I'm putting 8 staff into that, and if it's not going down, what am I doing with my money? I think. So there's a big issue, I think, around that and what the solutions are. Sorry.
Just for noting, our sickness absence within adult social work and social care has been reducing. We've had an intensive piece of work over the last year to identify what the issues have been. And yes, there's some issues related to performance, but certainly there are some other issues which are around for our staff group. So it's a piece of work that we have been concentrating on and will continue to concentrate on to see further improvements.
Chief Officer, and then Mrs. Summers.
Have you any idea?
Chief Officer first, sorry.
Oh, sorry, I didn't see.
It's okay, Maureen. I was merely just going to say that we had a presentation on Healthy Working Lives at our last local partnership forum, and are looking at how we can take that forward within the Health and Social Care Partnership. It is amongst the range of issues that challenges us, because it was a health employee presenting to us in relation to a health initiative, but we want to look at how we can build that around the work that's also taking place in the council, and create an integrated piece of work around that.
Have we any way of distinguishing between absenteeism through physical illness or people going off to have an operation, things like that, and work-related stress? Do we know what the proportion is for that?
Ms. Fraser?
Couldn't give you the proportions just now, but yes, we certainly record absence in under several categories, which include that. So we're able to identify whether it's down to work-related stress or whether it's more physical issue.
Does that show up, or are you allowed to say that? Does that show up that work-related stress is a big part of absenteeism?
Work-related stress is recorded and it's variable. It's not necessarily one of the most big, the highest issue for absence. It can be around physical health. It can be in relation to other personal stresses as well that people will report absence. So it's a whole range.
It might be something for us to look at in more detail in the future, the sickness, absence and healthy workforce. And I don't know perhaps whether it's better at this committee or at the Clinical Care Professional Governance, but certainly those are discussions that we could have and then bring it to the appropriate forum. Are you scratching your head, or is that another question? Councillor Drysdale.
Thank you. I have a question regarding the Care Inspectorate inspections and the narrative on page 27 or page 35 of the paper, and following on from that. I suspect the Director is in a good position to answer this from his work experience. Comment is made that an annual timetable of visits is agreed with providers, and I'm aware that the majority of inspections by the Care Inspectorate are announced and known about in advance, and therefore the opportunity is given for staff to prepare. There's certainly a number of unannounced visits as well. I do get that, but it seems to me that there are quite a lot that are unannounced. Would it not be more valuable if more, if not all, of the annual visits were unannounced, so that the inspectors could see how things really are?
It looks as if we moved on to the next section. Chief Officer.
Just to advise that all inspections carried out by the Care Inspectorate of care homes will be unannounced, that there are statutory requirements for every care home in Scotland to be inspected at least once a year, and that would be an unannounced inspection. Many of them will only be inspected once a year because that inspection determines that they are performing at an adequate or good level. However, many care homes will also receive a second or sometimes a third inspection, and again those would be unannounced. Generally, most services are the subject of an unannounced inspection, whether that's the annual inspection that's prescribed by statute, which applies to care homes and secure care and care at home services. The exceptions to that would be those services like, for example, a housing support service, where the inspectorate would be turning up at an office base which would not always be occupied. And in those circumstances, a short notice inspection may be announced. So just to reassure Councillor Drysdale that in most cases, providers will not know about the imminent arrival of an inspector. The slight qualification about that is if you are a care home and you haven't been inspected for 11 months and 3 weeks, you can work out what's coming next week.
Thank you for that clarification. It's just the phraseology, annual timetable of visits are agreed with providers.
I think we need to refine that to reflect the something more akin to what I've just described.
Mrs. Campbell?
Sorry, it was just on that point. I'm wondering again if it's just confusion and it's only, you know, previous experience of myself. I think that when they're referring to contract monitoring officers, that's the officers of the council that visit all care homes once a year under contracts and compliance, and that is an annual timetable and they are made aware of those visits. Hope that helps.
Chief Officer?
That helps greatly. So there's the distinction between the external scrutiny that's applied by the Care Inspectorate, but that point and this point and the annual programme actually pertains to our internal quality assurance and contract compliance, and that is, as Bernie has helpfully suggested, an annual timetable.
Just one little follow-up to that. In terms of the words used to describe the you know, excellent, very good, and so on, is adequate?
No. The Care Inspectorate, I'm able to tell you, and I won't be divulging any secrets here, has concerns about the use of the phrase adequate, because there is a tendency, or there can be a risk, that some providers will say, well, I'll settle for being adequate, and we should probably never settle for being adequate. But what we perhaps could supplement this by including is the information that is included in the quality framework for inspecting care homes for older people, which provides a far richer narrative in relation to each of those 6 categories to explain that this means that adequate, the strengths just outweigh the weaknesses, and that challenges providers to think about getting to a position where they're good or very good. So we maybe need to elaborate a wee bit on that in this table, but certainly no longer as a regulator, but as someone who commissions services and who runs services, we would not be settling on the adequacy of provision when we're talking about making a difference to people's lives.
A similar problem that we have in relation to schools, the satisfactory being that the majority of positives outweigh weaknesses, and there's a clear perception issue there about what's good enough and what isn't. Any other questions on Section 3, scrutiny and inspection of services? Chief Social Work Officer.
I suppose it's a question and a comment, and probably Chief Officer might like to say something given his previous background. But if you look at the profile on page 35, and noting that 93% of grades awarded to care services across Perth and Kinross in the previous model of inspection were sitting at good to excellent, then that is a very positive profile for an authority. Would you agree?
I would. And I would also commend to the committee members the page 26, which talks about very good, excellent, very good, excellent, very good performance of in-house services as regulated by the Care Inspectorate. Those are services run by the council over and above the ones referenced elsewhere, which includes the ones that are commissioned. So I think in relation to those staff who we employ, as well as those services we commission, we need to be taking time to ensure that we congratulate and celebrate the success and effectiveness of their day-to-day work in making a difference in people's lives.
Thank you.
I think I'm going to take some lessons from the Chief Social Work Officer of how to phrase a comment as a question, because we struggle with that at full council meetings. Any further questions on this section of the report? Okay, if we now move on to what I think is the final section before the appendices, which is section 4 on financial matters. Do we have any questions on this or comments? Councillor Drysdale.
Thank you, Chair. Yeah, just in relation to on page 40 or 32, depending on what you're looking at. Throughout 2018-19, funding was received for from Scottish Government for a number of initiatives. These included mental health action, alcohol and drug partnership funding, etc., etc. The underspend of 2.5 million against these funds has been transferred to an earmarked IJB reserve for future year commitment. Given the recent publicity and headlines around the number of drug-related deaths in Scotland, can you clarify for me, remind me probably, because I should know this, whether we do have an underspend of allocated alcohol and drug partnership funding in Perth and Kinross, and if so, why that is?
Chief Financial Officer.
Yes, there is a proportion of the 2.5 million that relates specifically to the area drug partnership funding. Some of that is historical funding that has been carried forward over a number of years, but some of that is much more recent government funding, of which the discussions are still continuing around the most effective use. But I think the chair and the vice chair of the ADP are very conscious of the need to focus the underspend to meet the increasing needs. We would seek to bring forward to the IJB those detailed plans, and to see the underspend moving into the next financial year reduced significantly.
Yeah, I mean it's clearly something where, you know, if you have a significant national problem that is commented upon by politicians of all persuasions at a senior level, and yet we have an underspend, it's clearly, you know, we need to just be able to justify that and to have plans for spending that money appropriately.
Chief Officer.
Absolutely. I mean, this is money that is supposed to be making a difference in and around communities, and we are committed to ensuring that we do so. Some of the challenges that we've had around particularly Action 15 money in relation to mental health has been around slippage, so full year money given to us but later in the year, so we weren't able to spend it all. And also the challenges around recruitment. We have had taken more time than we would like and not always delivered the output that we would aspire to when we've sought to advertise posts. So that's something that we need to look at, and we will be seeking to ensure that the money is spent on the posts that will make a difference when people either are in prison or are turning up at a GP practice or are needing supported in the community. So we're committed to look at that and to try to advance that.
Thank you. Mrs Summers, did you want to make a comment or a question?
I just wondered, you know, about the credibility of actually spending millions of pounds to refurbish Car's View when there's a lack of, you know, enhanced services in the community, which we've been promised for years now. I mean, it's millions of pounds we're talking about, you know.
Chief Officer.
So the investment in Car's View is a recognition that no matter how well and how effectively we deliver a community infrastructure that enables people to stay well and stay in their own homes, we will always require to provide beds and inpatient care for people whose mental health conditions are the most acute, hopefully for as short a period as possible. But that investment reflects a commitment to ensure that that experience is in an environment that is as effective and patient-centred and comfortable in order to support people to achieve recovery. It is a significant investment. I would not wish to confirm that it is millions because I don't have the figures just to hand, but it is not at the expense of the investment in community services because it would be a capital rather than a revenue expenditure.
Any further questions, Mrs Kilpatrick?
I'm just keen to understand what we are doing to stabilise and perhaps reduce the prescribing overspend.
Chief Financial Officer.
The last meeting of the IJB formally received the financial plan for prescribing. Within that were a number of initiatives that sought to significantly reduce the overspend. One of the key cornerstones of our approach is the work that we're doing directly with GPs, using data, a new data system that has been developed locally to look at variation between GP practices and use that to identify key areas to work with each GP practice with individual programmes of work to improve quality but reduce spend. So there's a significant savings target attached to that. That was one of the big cornerstones of the approach being led by Hamish Dougal.
Right. And can I ask, have you got prescribing advisors in practices? Do practices have because that's something we've been doing all over Scotland, is putting community pharmacists into practices so they can work with GPs. It's not a the problem, and I hear what you're saying, and that's really good, but the problem with retrospective analysis of data is it's already been done, we've already overspent, and it's quite hard to change behaviour like that. Whereas if you're the primary care practitioner is in, the pharmacist is in the practice, they can be working much more closely. So that seems to be the most effective approach. I just wonder if you're doing that.
So all of our pharmacists are practice-based, they're practice-attached.
Right.
And they work directly with the GPs in and around prescribing initiatives. So that's we've had that for quite some time, actually.
Right.
So.
Just to supplement that, the money approved by the IGB to invest in effective GP prescribing, taking quite a flexible approach to the utilisation of that money. So rather than just be about backfilling GP time, a lot of that has been ensuring we've got the requisite pharmacy support. Right. But how that looks, you know, across each of the practices, we would need to get further information on that.
Right. Okay. Thank you. Thanks, Chair.
Councillor Drysdale.
Sorry, are the questions including the appendices at the moment?
No.
No.
You keep jumping ahead. Councillor Stewart, is it a question on the current business?
Yeah, there are two references in this section to the difficult national economic outlook. I think that goes beyond the scope of what should be in an HSCP performance report. If we're going to be operating under tight financial constraints, it's because of the settlement that is devolved. It's the settlement that is devolved to the partnership. Difficult national economic outlook is too political and arguable, and I think we should just take that reference out.
Chief Financial Officer.
I would disagree. I mean, we've talked earlier about the need to look at our performance compared to the rest of Scotland and indeed England and provide a sort of baseline context for comparison. We haven't done that here, but we've made a broad statement that things for partnerships across Scotland are very, very challenging. I think that's a legitimate statement to make in this section.
I think if you're talking about perhaps we should have a discussion about that after the meeting, if that would be okay, Chief Financial Officer.
I'll refrain
Sorry, can I come in there? I think I absolutely
point.
agree with the Chief Financial Officer. I think it's contextual, and I think as any strategic plan would have to be looking at the context in which you operate and looking a little bit ahead. You're always, I mean, you're not planning for this week or next year, or even you're planning 3 years and potentially 5 years. So the contextual change, the context of the economy is not, well, I was going to say it's not likely to get much better, it might get much worse. I think it's important to say, I agree with you, I wholeheartedly agree with you. If I was a consultant and I was writing a strategic plan, I would include it. I think it's really important.
Chief Officer?
I concur, and I would be concerned if this report was being suggested to be political. This does not say that the Council has given us less money because the Scottish Government have given them less money, because Westminster have given them less money. This talks about the fact that we are operating in a relatively reduced financial settlement and an increasing demographic challenge and raised expectations and a commitment to try to work with people sooner to enable them to not become well, not become patients, not become service users. I think it's contextual, I think it's valid, and I think it's what challenges my staff day in, day out, and it would be wrong to remove it.
I think all of the points there, though, don't address the question of the difficult national economic outlook, which was the question that Councillor Stewart raised.
Yeah, what is the difficult national economic outlook? You're looking at a UK economy which is the #1 investment destination within the EU. You're looking at record low levels of unemployment and record levels of high employment. You're looking at wage inflation outstripping price inflation. If we're talking about the national economy, I'm just saying that the words here are not addressing the point that you are making, which is about the settlement to the Health and Social Care, the Integration Joint Board and the Health and Social Care Partnership. If you want to change the wording or couch it or more differently, then fine. But I just think there's no context or justification for using the phrase difficult national economic outlook.
I think we move on from that point and note the difference of opinion. Okay. Councillor Drysdale.
Sorry, this was on...
Did you have another question?
No,
oh,
no,
no,
on
on the appendices.
Yeah. You're ahead of yourself now.
Any further questions on finances? No.
Sorry, can I just say one thing? Yes. I think you're to be commended on your report. I think it looks good, it reads well. And I think you're very honest about what you think you still need to do and what's in the pipeline and what you're already working on. And I think it's a good piece of work. And I think it's something for your staff to be proud of. So I think well done.
Mrs. Summers?
Just a final word on Carsview. Who decided that any centralisation, if it had to take place, had to be at Carsview? Because Carsview is not the centre of the geographical area of Tayside. It also wasn't a fit-for-purpose building when it's got to have so much spent on it. And I just wonder why Murray Royal, which was a centre of excellence, could not have been used. And, you know, there would be less travelling for an awful lot more people. Centralising in Dundee, the Dundee people are not going to go anywhere. You know, they're in Dundee anyway. It's far more people having to travel, and that's not been taken into account when this decision was made, and the fact that the building wasn't suitable. So I just wondered why.
I think, Mrs. Summers, I completely acknowledge your points and your concerns and share some of the concerns that you have. And clearly, I think it is appropriate that you do share them at this meeting, because any strategic decisions do have an impact on our performance. And we know that the decision was taken back in January 2018, and as we know, there are further ongoing discussions that need to be had about the current situation. So it would probably be better to address them when we have that opportunity, if that's okay. But I acknowledge the points. Okay, if we now move on to the appendices. I won't take them one at a time. We just do them in order. Councillor Drysdale, your question.
First of all, as a comment, which is delighted to see Appendix 2 and the highlights, you know, being set out in a very readable and interesting manner. And you know, I think it's so important that amidst all the challenges that we confront on a day-to-day basis, and officers confront in particular on a day-to-day basis, that that we do highlight the good news stories that there are, and there are plenty of them. So thank you for that. And one in particular that I just wanted to ask about, which is the Perth City Centre Community Hub. I wonder if I can ask for a bit more information on that, given that, you know, a bit of a conflict of interest as elected member for Perth City Centre. Page 44 and 45, 44 of the papers at the bottom.
we referred to earlier, this is the work of the Health and Wellbeing Networks, and one of the outputs from the Perth City Health and Wellbeing Network is to develop a hub. So it's at very early stages at the moment in terms of creating I wouldn't say a one-stop shop, but somewhere where different services will be available for people to come in, but also really focusing on community resources.
And where would that be?
I don't want to give that commitment, but so I'll follow that up.
It'll be our little secret, right?
No, it's not a secret, but I've got two at the moment going on in my head. So.
Well, I mean, but there may well be some commercial sensitivities, so I think we will update you in due course and other elected members for Perth City. But I think we can provide you with the information that you need to.
Okay, thank you. And as I say, good news stories need to be shouted from the rooftops. So thank you for that. I had 1.5 more questions. Firstly, on page 46 out of 58, the section on national health and wellbeing outcomes, primary care improvement plan. Again, just can you set out for the record, we're saying here GPs positively engaged with this portfolio, and 19 out of the 24 practices within the health and social care partnership area have engaged in undertaking this work. What about the other 5?
I don't have that information to hand, but I'll get it. I'm really not clear why they wouldn't have engaged, so I'll have to look at it.
Yeah.
Okay, that's fine.
I mean, it is quite a concerning proportion. If it's just, the discussions haven't got to them, then so be it. But if it's the fact that 5 have been invited to engage and haven't, then that's a different story. And
I suppose some of it may well be just due to capacity within the practice itself. I'm happy to clarify.
Thank you. And my final, not so much question, but comment is in there's 2 points that have been made here. Firstly, the section on page 50 regarding housing for people with particular needs, which is a fantastic good news story. So good, in fact, that we repeat it on the following page verbatim. So it's in here twice. But I think, so it's on page 50 and on page 51. So perhaps we need to lose one of these. And finally, you'll be devastated to learn from my good self today, under employability network on page 53. I'm confused by the second arrowed bullet point, if I can call it that. The review report also detailed there was a slight increase of 5% in the number of employers engaged compared with 2018-19 performance review. Then goes on to say 565 employers to sorry. I was trying to be smart. That's right. Sorry.
It was a shame to end on a question like that. But,
I peaked too early.
about an hour ago. Councillor Stewart, did you have a question? I see your microphone is on.
Yeah, I think it was a question. So Appendix 2 is billed as highlights of 2018-19. And it is worth remarking that there are a great number of highlights in here and good practices, which I hope we don't just report on, but make sure that we cascade out throughout the health and social care partnership. If something good is happening in one locality, we need to share it with the others. If something good is happening in one part of our service, we need to make sure it is spread throughout. I do want to come back to a question that Councillor Purvis and I asked when we were having the discussion about the draft of the annual performance report, which was should we include some lowlights and a page to focus on, or at least to draw out and summarise the from this annual performance report what the areas for improvement are. Individually throughout the report there are some points made, but I think it is important that in discharging our public duties as a board, we are honest with ourselves about the performance of the partnership, and that a summary page of areas for improvement would be a positive step in recognising and addressing those areas.
And the key point there in terms of the suggestion was not a full improvement plan, as we will obviously look at that through the Audit and Performance Committee and the IGB itself, but just a summary of those points. We did have a discussion about that. I don't know, was the decision taken not to include it, or is that still to come?
Can I suggest that we reflect on that and reframe it as priority areas for improvement moving forward, that distinguishes the green from the red and provides a bit more richer narrative and more explicit and smart objectives about what we're going to do that you should then see read across into the strategic commissioning plan?
I think that's the, you know, areas for improvement was exactly the point I was highlighting. We are doing the annual performance report before the strategic commissioning plan. I think if there was a summarised areas for priority areas for improvement, then that would help inform board members when they come to agree what the content of the strategic commissioning plan going forward should be.
Okay, do we have any further questions or comments? Mrs. Summers.
Just want to ask, I've had a quick rush through this, like, you know, and really just concentrating on the pages where there's been questions asked. Would it be all right for anybody around here to go away and look at it? And is there a time limit to comments on page? Or is this it? You can't comment after today, or, you know?
The Chief Officer?
I think it's really perhaps for the committee to determine whether or not they are happy for us, content for us to take the comments that have been made in the course of today's discussion and finalise the report, including taking it to our colleagues in comms and getting the work done on it, or whether they would wish to see the next and final iteration. And given what we've heard about the Scottish Government aren't, you know, anxiously waiting for us to submit, it's really perhaps for the Chair and committee members to advise us in their preferred approach.
We're going to be talking about a few days, you know, just to have time to go home and read it properly, that's all.
When is the current, if we were to approve it today, would we be on track to submit it by the end of July?
My understanding is that it's the publication is for the IGB to decide, so that the guidance is that should be published before the end of July. I'm looking at Sandy. So in terms of submission to Scottish Government, that will happen, but in terms of the IGB approving it before the end of July is the guidance.
And you mean the IGB, sorry, the IGB generally, including the Audit and Performance Committee, which is, yeah, okay, that's fine. I think that I'm happy to suggest that we approve it with the corrections, alterations and additions that we have said in terms of publication, but perhaps there could be something, because maybe the next steps might be something that takes a little bit more work that we could see before that then formally goes to the Scottish Government, if that's the issue in terms of the guidance having to publish it by the end of July versus submission.
It's really for us to make public. So we've already we have a draft that's made public before the end of July, and now we will actually we can take the comments, we'll be able to make those amendments, and then we'll submit that to the design team for publication on our website.
Chair, can I suggest it may be possible for Maureen and anyone else who has any further questions to ask or points to make them over the next couple of days, and that if there's anything considered material for us to be circulated on it, but if not, then these comments could be incorporated with a view to the final draft of the report being completed by the end of the week, if possible.
I think that's fine. I think that's what we were suggesting, if people are happy to approve it on that basis. Looking for an indication from committee members. Yes? No? That's only 2 votes. Mrs. Kilpatrick? You're happy? Okay. Ms. Campbell? Okay, that's all the voting members. Okay, that's fine. It's approved. Okay, thank you for your attendance. The next meeting, I don't actually have the date for it because it's a special one. Do we know when it is?
8th of September.
Sometime in September. Okay, thank you all. We'll just get committee services to bring it up, yeah. Oh, no, to check now to tell you.